Mood disorders. So our mood disorders are separated into two different sections in our DSM. We have bipolar and related disorders, and then depressive disorders. So first, let's dig into the bipolar disorders, and this includes bipolar 1, bipolar 2, and cyclothymia. So for bipolar 1, we are looking for evidence of mania. And so manic episodes are periods of abnormal, elevated, expansive, or irritable mood. So noting that it's not always erratic, elevated mood. It can be overly aggressive or irritable, particularly for men. These can be highly goal-directed activities. So like, I'm gonna paint my entire room and I'm gonna do it overnight. Energy persistently lasting at least a week. So these individuals, when they're in a manic episode, may not need to sleep because they're just so amped up. And so they have a lot of energy lasting every day, most of the day. And so for it to classify as bipolar 1, there has to be evidence of some sort of manic episode in addition to the depressives. And you want to make sure that these mood symptoms are not just side effects of an antidepressant. So sometimes when someone is experiencing major depressive disorder and then they start an antidepressant, their mood can sort of swing completely in the opposite direction, and they can present with something that looks a lot like mania. But if that mania has never been present except for after when they've started taking this antidepressant medication, you would want to rule out that as the cause of the manic type symptoms to make sure that it is not bipolar 1, it is likely just a side effect of a medication. So for bipolar 1, during this manic episode, we have to see at least 3 of these symptoms. There has to be inflated self-esteem or grandiosity. I'm amazing, I'm so attractive, nobody even compares to me, I am brilliant, I am the best person that ever walked the face of the earth. Now this is different than delusion. Delusion is like, I am literally Jesus. Mania, grandiosity, is just a really strong sense of self-esteem. I'm incredible, nothing can touch me. And this might lead to some of these other types of symptoms, things like impulsivity, and decreased need for sleep. So we're going like days on end without sleeping. There's pressure to keep talking, so they talk and talk and talk and talk, and they just cannot have enough hours in the day to say all the things that they need to say. And again, we want to rule out things like ADHD as a cause for this. This is just specific to the mania, so it's not something all the time, it's just within this manic period. There's racing thoughts. Here, obviously, we want to rule out things like anxiety. Again, is this going on all the time, or is it just within the context of this manic episode? Easily distracted. This may be something that the client shares with you, or it may just be something that you notice. So in your intake interview, maybe they change topics like 6 different times in answering a question. And again, wanting to rule out things like ADHD and anxiety as a cause for that. Increased goal-directed activities. So I am going to organize my entire house and I'm going to do it right now, or I am going to write this entire paper right now. Or engaging in risk-taking activities. This can be risky sex practices that are not typical for this person. This could be driving really fast. This could be impulsive behavior, or maybe jumping off of tall objects because you think that you can't be harmed. These mood changes need to be severe enough to cause impairment across different areas. And so again, looking for marked changes in social occupational functioning, various areas of a person's life. It may have psychotic features. That is an option. We have a specifier for that. Mood changes may require hospitalization to prevent harm to self or others. Particularly in this manic phase, we might see a lot of potential self-harm. And we have to make sure that this is not explained by substance use. For example, methamphetamine could present a lot of similar symptoms to mania. So are these things only present when they're under the influence of that substance, and or not explained by medical causes or side effects of medications? So we do also have this option for hypomania, which is not quite as elevated. So abnormally elevated, expansive, or irritable mood, goal-directed activity or energy, persisting at least 4 consecutive days. So think of it as manic light. This is not quite full-blown mania, but it's a lighter version, a watered-down version of mania. And again, wanting to watch out that these are not side effects of starting or adjusting to a dosage of an antidepressant. So we see a lot of the same options in terms of needing 3 or more criteria met in terms of symptoms. Unusual change in functioning, which is uncharacteristic of that person. The mood changes need to be observable to others, so this is noticeable change. No psychotic features, or not severe enough to cause functioning changes. So hypomania can typically be managed pretty well, but it's definitely uncomfortable and notable. The final piece of bipolar 1 is we have to have that major depressive episode. And the difference between major depression and bipolar 1 is that that person has experienced mania or hypomania. It's not just the depressed mood, which again is why we have to rule out that side effect of antidepressants. So for the major depressive episode, we notice a change of functioning, and we have 5 or more of these criteria present most of the day, nearly every day for at least 2 weeks. And you'll notice that in the world of depression, 2 weeks is sort of the magic time frame. So we want to look for things being around for at least 2 weeks. So we notice a depressed mood most of the day, nearly every day. This may be reported by the client or just something that you notice as a clinician, because again, that observation is really important. Lack of interest or pleasure in almost all activities. So maybe they aren't feeling down, but they just aren't interested or find pleasure in anything anymore. You might also, unintentional weight loss is something that we notice. That's a big indicator of depression, or either insomnia, meaning that they can't sleep, or hypersomnia, meaning that they sleep all the time. Also, options include psychomotor agitation or retardation, meaning that they're just moving slower. Moving is hard. Fatigue or loss of energy. They're just feeling really tired, feeling really worthless, or maybe have excessive and inappropriate guilt about things. Lack of ability to concentrate, indecisiveness. And again, this is because they're so slowed down. They just can't get to a threshold of making a choice. And then, of course, always wanting to look out for suicidal ideation here, with or without a plan, with or without attempts. So this is causing distress across areas, not better explained by side effects of medication, substance use, or other physiological causes. And in recent years, bipolar 1 has become a bit of a popular diagnosis. So especially with children, we saw ADHD diagnosed quite a lot through the 90s and early 2000s. And then it sort of shifted to bipolar 1 being a really popular diagnosis for kids, which is a little concerning because honestly, bipolar 1 uses some pretty heavy medications, and there's some pretty big implications for using those on young brains that are still developing. And that's not to say that bipolar 1 does not happen in kids, but it's been diagnosed increasingly more. And now we're seeing a big shift to oppositional defiant disorder being sort of the popular common diagnosis for kids. So noticing, because bipolar 1 and bipolar 2 are a little bit difficult to differentiate. So you have to have had at least one manic episode at some point in your life to qualify for a bipolar 1 diagnosis. Hypomania and major depressive episodes are common but not required. Really the key here is that they've had mania. So you could see someone who has periods of manic and then periods of hypomania, but they don't quite dip into full-blown depression. That would still qualify. So you don't necessarily have to have that depressive piece, but you do have to have the mania piece. So one manic episode, and that can be before or after either hypomania or major depressive disorder. And so you want to rule out things like major depressive disorder, obviously, or prolonged grief disorder, which is a new option that we have in the DSM-5 text revision. So their response to a loss may have similar symptoms, may stretch beyond what's appropriate. In the case of prolonged grief, we're looking at about 6 months. And noting that the primary symptoms of grief overlap a lot here. So it's emptiness, a sense of loss, decreased sensitivity to stimuli. So we definitely want to rule out that grief piece as part of this. And then of course we have specifiers of mild, moderate, severe, and an option with psychotic symptoms. And then we have always the partial remission or full remission, meaning that with medication and other interventions, these symptoms are pretty much under control. We do want to rule out psychotic disorders. So again, is it the psychosis being the primary and the mood symptoms are secondary, or is it the other way around, which would be more indicative of bipolar disorder? We have lots more options of specifiers with bipolar disorder. We have with anxiety, with mixed features, with rapid cycling, which means that they change pretty quickly. In fact, at one point I had a client who would rapid cycle within the day. So, I mean, even within an hour of therapy, we would see them go from really elevated mood to really depressed mood really quickly, which is not terribly common, but it does happen. Melancholia is loss of pleasure and reactivity to external stimuli. We have catatonia as an option. And then, of course, psychotic features, including delusions or hallucinations. And we have postpartum bipolar disorder, which means that it's something that only presents within 4 weeks of having a baby. We also have seasonal patterns where, for example, the depression phase of bipolar maybe only shows up in the wintertime. So just to help you differentiate a little bit the difference between bipolar 1 and bipolar 2 and cyclothymia, this chart is really helpful. So noting that the big key indicator with bipolar 1 is that you go all the way up into the elevated category of mania in terms of positive symptoms. And with bipolar 2 and cyclothymia, we never quite get there. So with bipolar 1, you can swing all the way down to major depression. With bipolar 2, we see that as well, and with cyclothymia, we don't see that swing as far up as mania or as far down as major depression. So I encourage you to take a moment and just have a look at this chart. It's super helpful as a visual to understand the difference between bipolar 1, 2, and cyclothymia. So cyclothymia is just sort of like, we nickname it the Eeyore disorder. So it's just sort of, you don't quite get as high as mania. You don't quite get into full-blown depression. You're just sort of blah most of the time. And then sometimes you get into what looks like normal mood. So this can be really difficult to diagnose because you don't see extremes in either direction. In bipolar 2, you would see the extreme of the depressive disorder and then somewhat of an elevated mood in terms of hypomania, but you don't see that with cyclothymia. So you have at least 2 years of hypomanic symptoms without ever experiencing full-blown mania and without ever experiencing a major depressive episode. But think about how long 2 years is. That's a long time to just feel blah most of the time. The symptoms have to be present at least 50% of the time, and the episodes can't be more than 2 months apart. So it is pretty miserable. Again, looking for a high potential risk of suicide with anything bipolar related in terms of disorders. And we would see impairment across multiple dimensions, not better explained by some other cause. Now with depressive disorders, we have 3 options. We have major depressive disorder, or MDD. We have persistent depressive disorder, formerly known as dysthymia, and we have premenstrual dysphoric disorder. With major depressive disorder, we see 5 or more of these present every day for at least 2 weeks. Because again, with depression, 2 weeks is a pretty important window of time. So we see depressed mood most of the day, nearly every day. This might be reported by the client or just something that you observe as a clinician. Diminished interest or pleasure in all or most activities. You have to have at least one of those 2 symptoms at the beginning of the list to qualify for the disorder. In addition to that, you may have weight loss, unintended weight loss. You might have sleeping too much or sleeping too little. Again, these are going to look pretty familiar from a bipolar 1 criteria. Psychomotor agitation or retardation, really slowed down, think sloth mode. Fatigue or loss of energy, feeling worthless, feeling inappropriate or excessive guilt, feeling diminished ability to be able to concentrate, feeling indecisive. And again, we see that potential of suicidal ideation with or without a plan because of that hopelessness and that worthlessness. As always, this would cause impairment across dimensions. And that's important because if someone's just really depressed at work because of the work environment, but they're fine everywhere else, that's not necessarily major depressive disorder. That's probably something really specific to their work environment. So that across dimensions piece is pretty important. And then we always want to rule out substances like alcohol use or marijuana use, for example, or any kind of underlying physiological issues. So the keys here are significant loss of interest and depressed mood. Persistent depressive disorder, we used to call this dysthymia, is essentially cyclothymia without the hypomania. So you're just sort of or blah all the time. So you have depressed mood most of the day for at least 2 years, no more than 2 months apart. So we see major depressive disorder sort of stretching out for a really long time. It may turn into this persistent depressive disorder. So while you're depressed, you see poor appetite, overeating, changes in sleep, low energy and fatigue, changes in self-worth, poor concentration, or feeling hopeless. The criteria for MDD may have been present for 2 years, but again, 2 years is a long time. And so it takes a long time to reach the point of this diagnosis. And because most people don't see providers for that long, we don't see this diagnosed quite as often. Again, we want to rule out any kind of mania or hypomania that would indicate perhaps a bipolar 1 or a cyclothymia diagnosis. And we see distress across dimensions, not better explained by a psychotic disorder, substance use, or some sort of medical cause. Finally, we have premenstrual dysphoric disorder, or PMDD. This goes beyond your typical PMS situation. This really impacts your life daily across dimensions. And so there's a lot of distress and it interferes in your ability to function regularly. So for the majority of your menstrual cycles, at least 5 days in the week before you start your period, and then see improvement of symptoms a few days after you start your period. So really you just see these symptoms present during that time of a woman's period. And so you have to have at least 5 of these symptoms, 1 or more from column A and 1 or more from column C. You see mood swings, feeling sad or tearful, a lot of sensitivity to rejection, irritability, anger, depressed mood, hopelessness, anxiety, tension, feeling on edge. And again, this is beyond PMS. This is to the point where it's interfering with your ability to function on a daily basis. And then C, 1 or more, decreased interest in activities, trouble with concentrating, feeling extra fatigue, like literally can't get out of bed level of fatigue, changes in appetite, sleeping issues, feeling overwhelmed, feeling like things are out of control, and just a lot of physical symptoms that might be going on. So again, before we go and diagnose our family and friends, because ethically we're not supposed to do that, just noting that we may giggle about this, but it really does impact these uterus owners' abilities to function, and it's pretty debilitating to go through.